Hi, and welcome to yet another episode on Ncdohtv. I'm Malik Gau, the man of the Midas Touch, and we've just had a wonderful, detailed budget vote for the Department of Health, and that, of course, in the Northern Cape. And I'm joined by the MEC for Health, Mr. Maruping Lekwene. What a detailed budget vote, and when one looks through the eye of where we're trying to go implementing NHI, districts are going to be fundamental. They're going to be the center, core of implementation in terms of health services. How do we then plan to strengthen districts in terms of health services?
Yeah, no, Malik, thank you very much for the question. You're right. NHI, it's been enacted into law by the president. Sometimes May this year. So your critical areas is going to be your district hospitals, which needs to be strengthened because district hospitals are supposed to be rooted where the people are. So we are having we've lined up our programs to strengthen our district services. And you know as well, district services in terms of our budget, they account for almost 45%, almost 50% of the budget, 2.1 billion to be specific, which is being allocated to district health, because it's where most of the services must happen in the 5 districts in the province. So in terms of we intend strengthening them, it's on theaters, it's on our clinics. It's also even on strengthening our EMS services. Let me start with our theaters. Currently, most of our theaters in our district hospitals are not full operational, with the exception of Abraham Esau Hospital in California. The last time, last year, I visited the hospital. As a young manager there, was quite a model for me. This hospital is clean inside and outside. They're using their theater optimally. They're running lots of surgical work there with some good committed team of doctors. So instead of referring all the cases to RMSH, which is Robert Malsum Hospital, they're performing those surgical work in that hospital, which is quite inspiring. And if we can operationalize these theaters to perform even minor surgical work, even amongst others to do even scissors, which are not complicated, to help our communities there. It will really help us a lot. So that's why we want to operationalize all these theaters, but we are going to use our specialists, our senior doctors from RMSH to do outreach programs in all these facilities, but also will be a way also of strengthening dispensing skill, giving skill to these other doctors in these hospitals, because most of them, they can't do the work. It's just a matter of confidence, because some of them are relatively young, so to perform that kind of terms of surgical work can be scary. But so we want to strengthen our work in the district to operationalize all our theaters in our district hospitals, which is quite important. And even our regional hospitals. It's very important. So we'll be dispensing our specialist teams from the RMSH to then strengthen the work at district level. But also doing that will also be allowing some doctors to learn from these senior doctors. And number 2, there's a demand in terms of services. If you check, for example, in RMSH, where we are, Romanso Hospital, it's always over congested, it's always overcrowded, because at 4 o'clock, most clinics are closing down around Princess Park. And then there's only one facility open for any emergency after 4 o'clock. It becomes RMSH. That's why now we've opened GDH, Halshwedi Hospital. Well staffed. I was told that we're having 8 doctors and a number of, I think, 12 to 15 nurses there for every shift, which is very good, meaning that we are ready for any eventuality, for every task. So we have not yet seen results for opening the hospital 24/7, because RMSH remains congested. There's always a high volume of people coming this way. But we'll have to popularize and inform our communities around Princes-Bart, especially in Salt Lake, that GDH is now open 24/7, so that for minor illnesses and minor cases, they must first start at their clinics. If they can't be helped, they must go to GDH. And then we must allow RMSH as a special hospital for special cases where a doctor is referred to RMSH. So it's part of our work, and it's an ongoing work which we need to be doing. We must not tire doing that. In Kuruman, in Khaskhonyana, there's the clinic called Kagisho SHC. We're going to also operationalize it 24/7 to work with one intentional objective, to also try to contest, to minimize, to reduce to overcrowding in the Kuruman, in particular hospital which is in town. Because many people around Kuruman, they go straight to Kuruman Hospital. They don't even start at the HCC or even the clinics. For all the reasons. Because they know when they go there, there's nurses, there's doctors. So we are going to operationalize Kagisho Clinic 24/7 in Khaskhonyane. So that even when the clinics around are closed, then the nearer communities and villages can just use Kagisho CC as a first point of entry. And then any serious matter, we can then refer them to the Kuruman Hospital and the site of Constantine Hospital. Here in Salt Lake, we have in the Torres Clinic, which is in Rhodopal, and the City Clinic. City Clinic, you'll appreciate that the number of students and people not staying in town has increased. Salt Lake accounts for more than 5,000 students. So most of them, I know they have a city, a campus clinic, which is not so big enough and well equipped. So most of them are using the city clinic. I was there several times. They phoned me. So there's a huge demand for the services of our facility there. So that's why we're not operating some of these clinics, Torres and the City Clinic 24/7. No, we're just increasing from 8 o'clock to 12 o'clock midnight, so that at least all the people around there, they must have access to primary health care services. So it's a program, deliberate program of trying to reinforce our district services, but also ensuring that our district hospital are strengthened and provide those services. And of course, they will need extra money because you have to get extra hands, extra nurses in particular, and even doctors in some other cases. Where we cannot recruit extra hands, we'll have to engage our current staff, those who will be prepared to work overtime. And then what we must do as employees is just to pay them their overtime without fail, so that they must be encouraged to avail their services beyond their normal working hours. Because most of the nurses and doctors are doing RWAPs, are doing what we call moonlighting. So if we engage them, we are quite confident. We might get some of them. We will be prepared to work for overtime, and we must pay them. So we will be doing that throughout the districts. But that's an interventionist measure. The ultimate or the ideal situation is to recruit more nurses so that we have proper shifts and then people work effectively. Because human beings also, they become tired. At times you just feel you are tired and you can't do overtime. So we're not encouraging the staff to do overtime, but for now, for a start, we'll do that. But the objective is to have permanent employees recruited to these positions. As you know, currently in the province, one of our key challenge is the recruitment of professional nurses. We're struggling. There's a huge shortage. With doctors, we're not doing that bad. We are well staffed. The only area where doctors will be with the specialist doctors, like your pathologists or psychiatrists, amongst others, where we are very thin on the ground because we are failing to attract such skills to the province. And thanks to the human doctors, some of them are performing the tasks for us. In fact, we even engaged that if we won't be able to get any, we'll have to also explore the option of getting more Cuban specialists to help us, because they'll be more willing even to work even in the far-flung areas of our province. In other cases, we do attract these skills, but when they hear that they must go and work in the remote areas of our province, many of them are young, cosmopolitan. They don't really get attracted to and work in the rural areas. Yeah. So they turn it down.
They are talking about rural areas. I hear MEC is talking about augmenting or even extending hours in clinics, which speaks to urban areas of the Northern Cape. Yeah. But there are those people that must walk or even drive kilometers, which are the rural areas, the hard-to-reach places. Yeah. How are we dealing with those type of patients in those areas?
That's a good question, Malik. In fact, I nearly forgot that one. For this financial year, we have procured 5 mobile clinics. 5 looks very small, but you know, the things also they don't come cheap. We would have loved to get more, but the intention is to get even more clinics. But for this financial year, we've bought 5 mobile clinics. We're going to give every district 1 mobile clinic. The 1 mobile clinic is not a station, a stationary in one place. For example, if we put 1 clinic, say, in Dikhatlo, say maybe Smuts Mine, it won't just do in Smuts Mine. It will go maybe to Olpan, Smuts Mine, and other areas. We'll have different dates where we can make the clinic available. I know in Pishlegasem and Colesburg in particular, there's been a request now for some years now, I think 3-4 years, if not 3 to 4 years, where the communities approach me and say, MEC, we need a mobile clinic. But also some of these targets are moving targets, because there are new settlements created all the time, all over in the province. And some of them, they grew really big. And as they grew big, they then become very far from the actual clinic. Then there's a need for interventionist of a mobile clinic. Mm-hmm. Check, like, for example, now, if you take Solpreki now in Rodepan, now at the back of Rodepan there is going to the military camp there. There's now a settlement there created, which is now far from the actual clinic in the middle of Rodepan. Very soon, people will be telling me that, let me say, we need a clinic. In Khaleshwe, it even was Snake Park, all these areas which have been expanding. There are no clinics around there. So that mobile clinic will have to assist them. The clinics which are there historically, because of the expansion and the growth of the settlements, they became a bit far, 20-30 kilometers away from the actual clinic, which is causing even more pressure on the mega budget waiving, even the staff waiving, meaning that we can't even afford, because a mobile clinic is not just a clinic. That clinic must be accompanied by, in other cases, a medical officer, a doctor, must be accompanied by a professional nurse, and maybe an auxiliary nurse.
And equipment.
Of course, and equipment is like that. And all what you will need to perform your duties. So it's not it's quite an expensive exercise as well. But as a Department of Health, we want to ensure that we uphold our mandate to make health accessible and ensure that no one is being deprived healthcare services as defined by our constitution. But the reality is that financial constraints will always be our problem in the province, especially for health department, given our mandate. The topography of the province, vast province, in most cases, underdeveloped, with the bed roads and all that. Which takes me now to my second point, which you asked me about the EMS. Ordinarily in the province, we're having 250 ambulances, which are there. But on a daily basis, we're only having 80 to 90 operational from the 150. The other 60, 50 is for the merchants. The merchants mean that they need to be fixed, maybe brake pads or to be serviced, or some mechanical faults, which also now it's an objective factor for us coming to the merchants. There's a Treasury has put the services on a transversal tender. It's been for every repairs, for any repair, we must go via West Bank. West Bank must give us an assessor. At times, they don't have enough assessors. That's all over in the province. They come after a month or two to your province. Meaning that for that month or two, your vehicles won't be fixed, which is putting more pressure on our services on EMS. It's quite cumbersome, I must say it. That's why in most cases, where we are being found guilty of not responding in time. And unfortunately, in some cases, some people demise us in the process. But what and then what to be blamed. And of course, our government or department, we can't say no, it's not us. But that shouldn't be happening. The longest wait for an ambulance should be less than an hour. Quick response within 15-30 minutes, the latest, the longest. But we're having these systemic challenges in the province, especially when in the far flung of the province. But even internally in our townships like Yen Khaleshiwe, at times it's becoming rampant, where I get a lot of complaints that let me say there are no ambulances. Let me say you are failing us. Let me say our people are dying. And I think it's a genuine call and it's a genuine concern, which for this financial year, Malik, we have procured extra 30 ambulances with 8 PTVs, patient transport vehicles, because in most cases, especially small communities, they use ambulances as a PTV. If somebody is being discharged at the hospital or a clinic, an old lady or an old timer, they take the ambulance to drive 30, 40 kilometers to take the person home. In that 30, 40 minutes, in that 1 hour, there's an emergency. There's no ambulance. And the worst part at times, one ambulance must travel up 3 towns, which is even the worst. So we spoke with the Premier about this matter. We're looking to augmenting our emergency vehicles to try and check maybe one ambulance must work within 3 wards only. It will be more effective in your urban and peri-urban areas. It might be a bit difficult in your rural areas. But where there's congestion in terms of communities, 1, 2, 3 wards will have 1 ambulance. So that's the plan we were busy with to try and revamp and try and strengthen our EMS services. But the other challenge with EMS services is not the vehicles, it's the personnel. You can have the cars, then you might not have the properly trained EMS personnel. Because ambulance is not about just a driver. You must know some basic elementary medical interventions. If you find someone who's sick, you must be able to stabilize the patient, be able to put in a drip, take the temperature and check what's the problem, be able to put up like a CPAP machine for oxygen. You must be able to really do basic things to help stabilize the patient whilst driving or him to a clinic or to a hospital. So with the national norms and standards, they are very strict. They want as an entry level maths and physics at matric level, which many of our young people who does maths and physics doesn't see EMS as a career path. No, they want to become engineers and doctors and other advanced maybe courses. The EMS is not one of them. So especially in our province with a small population, we're really struggling, especially in smaller towns. We're struggling to get learners or pupils who have studied or have passed maths and physics just to train them. So we're engaging, of course, with working closely with national. Last week, we had a retreat which was convened by the Honorable Minister, Dr. Mutsoaledi, just to have a common understanding on this broad mandate and critical mandate of provision of healthcare services in the country, on the common challenges and the strengths and capacities, but also on the opportunities which are there. Also on low-hanging fruits, what can be done immediately to resolve some of the challenges, especially on staffing, getting more nurses, getting more doctors, but also our ability to respond quickly to the demands of our people. So EMS, of course, it's one of our key challenges in the province. If I must sum up our challenges in the province, there are 3 fundamental problems in the province, in our department. Health, a shortage of staff, both doctors and nurses, but also, I forgot to make the point, there's also a huge shortage of non-clinical staff. There's a need for cleaners, there's a need for porters, there's a need for groundsmen, there's a need for clerks. It's very important we must fill those posts, because in the value chain of healthcare services, every position in health is important. For a doctor to perform a surgery in a theater, he or she must want that theater clean. After every operation of the clinic, after any surgery, that theater must be cleaned. If it's not clean, then it means that he can't continue with, or she can continue with the next operation. Mm-hmm. So the value chain, if a patient must be taken to a ward or to visit a doctor, there's someone who must push it from the ambulance to the doctor. You need a porter to push that patient from that point to the next point. If that patient has been helped by the doctor in a whatever consulting room, that patient must be pushed to a ward or to the next consulting process. You need porters. You need cleaners who must keep the hospital clean, because you can't. Hospital by its very nature must be clean. It's about compassion. You can't have dirty hospitals or dirty clinics.
Some of the questions that, as you were busy with the media briefing, some of the questions that came, or one of the questions that came, in some countries, if they can't procure or afford to procure or import something, they manufacture theirs. So in this case, the question was, what's happening to Henrietta Stockdale?
Yes.
Nursing college.
No, excellent. In fact, there's the only college we're having in the province, by the way. It's an old college. It's called Henrietta Stockdale College, Nursing College. It has been helping us to produce our own nurses. In fact, that's what we're supposed to be doing with that college. But unfortunately, in the last 23-24 financial year, even now, last year, Nursing Council, South African Nursing Council gave us 30 learners to be enrolled for the new diploma course and even certificate. We couldn't proceed with that because the higher education department has then accredited those qualifications. It's our responsibility as a health department to train these aspirant nurses, young people, but for them to have the qualification, it is the jurisdiction and the responsibility of higher education. It means that we cannot just train them, we will just certificate them. Because after that, they must be enrolled in their professional bodies. And the only accredited and legitimate body to allow them to be trained, it becomes education, which is another department now. Doesn't reside with the Minister of Health. So it's been to and fro. The last time I was told there's progress. Again, when I call the team, it's a matter of giving attention, Malik. But you're right. The focus there, we must train our own nurses, especially for the rural communities. We must recruit many youngsters from all the rural communities in the province, train them, and send them back to their communities. So that's what we did with the Cuban Doctors program, the Fidel Castro Nelson Mandela Scholarship program. Unfortunately, because of financial constraints, we couldn't even get more to the program. Last financial year, we sent 10 of them. We took them from the far-flung rural areas of the province with one objective. When they finish training, they must go back to the communities and blow back and then work for the people in and around and surrounding towns and villages where they're from. I remember sometimes last year, we recruited 2 young nurses from Free State. They were keen to come and work in the province. When they learned that, no, you're not going to work in Kimberley, you're going to work in Smutsdrift. Smutsdrift is 70 kilometers away from Kimberley, a small rural community. They turned down the offer. I said, no, thank you very much. We're not prepared to go and work there. There are no flushing toilets there. There's a problem of water there. There are proper roads. There's not even proper transport for us there. We're not going there.
Sorry.
So the ability to recruit the needed skills is quite cumbersome in the province, given the rural nature of our entire province and the vastness of it. Because to do work in the province can be seriously tough. A patient from a CC to a district hospital and then to a hospital, you'll have to travel even 1,000 kilometers just for that operation. In other areas, cities, maybe in other provinces, they can just travel for 20, 30 minutes. And that's even less than that. So these are the impediments which, in realities, we're doing work under. We're not complaining. We are from this province. We know understand the province. But to do work here, we must go an extra mile. And at times, it makes it a bit difficult to provide urgent and immediate health intervention. Yeah.
Time is not on our side. But thank you so much for coming through.
Yes.
Your very brief last message to our communities out there.
No, thank you, Malik, for that one. From my side, as the Ministry for Health, is we are committed to provide healthcare services to our communities, albeit under very difficult conditions. Our nurses, doctors, and entire staff, our healthcare workforce is working under tremendous difficult conditions, and at times we don't appreciate them. We must appreciate them. We must thank them. There are a lot of good men and women working for the department. We're ensuring that our people get helped, they save lives, and we hardly say to them even thank you or as an extra graduation amount or some extra salary, but we want to thank them and say to them they must continue to do the good work. Most importantly, as a department, we must always strive to be professional. We must enhance professional our work. We must ensure that we do everything within our best ability to help our communities, to save lives, but to ensure that we change the image of the department. Healthcare is a right. And every South African have a right to healthcare services. And all the staff and colleagues in the department, no one must do us a favor by performing your duties. We must do it with pride and with dedication and commitment because we're all employed to do our part. So we're requesting that just do your part. If you must do it from 8 to 4 or 8 to 5, do it with great dedication. And we are here to give support and to play oversight role as the executive authority. And where we can, always intervene, always help our communities. But we want to recommit ourselves that we are trying our level best to ensure that we provide healthcare services. At times, I know there are serious challenges, and where we can't really do our best, we want to recommit ourselves that we will improve. And but we must do it together. We must hold hands and work together for the betterment of our province and for our own people. Because from the 1.34 million people in Northern Cape province, it's only 13% who have medical insurance, who are medical insured, who belongs to schemes. The rest solely rely on public health care. They rely on us to provide this important service, and we dare not fail on it. Malik, thank you very much for your time with your team.
Thank you so much, MEC.
Yes.
And we'd like to thank the MEC for Health in the Northern Cape, Mr. Maruping Lekwene. We just had a wonderful chat with him. And of course, let's continue living healthy, eating healthy, little nyana gardening in your yard or for vegetables and exercising, walk around the house. That's how we start. And then walk around the block. If you can't, put some hype music in your house, jump up and down. That's a good exercise for you. But hey, let's continue living healthy. The responsibility for your health lies squarely on your shoulders. And I'm Malik, the man with the Midas touch. And this is Ncdohtv. Bye-bye.